started, I'll first introduce myself. I am Dr. Wesley Smith, as you can see there on the slide, co-founder and the Chief Scientific Officer of HealthSnap. I am very excited to talk about these remote therapeutic monitoring codes that are coming out in January. But keep in mind, I'm going to be talking about this from a scientific perspective and from a perspective of someone that really believes in proactive digital care more than from a compliance standpoint and from a regulatory law standpoint. That's not my forte, and I'm not going to pretend that it is. From that standpoint, I will cover what is known online, but I really want to talk about how I feel that this is really important for us in this digital care wave. It's just another sign, I believe, of healthcare transitioning to more and more remote technology for proactive care. This is something that I specialized in doing in research at the University of Miami as HealthSnap evolved from a research and internship academic program and escaped that silo into the world of innovation. And it's because I believe very strongly in using technology and using remote care to make it more convenient for patients to improve care. So if you're like me and you find that to be exciting, then you recognize that we're in this sort of transition from blockbuster video rentals in healthcare to a Netflix era. And it's not just the physicians finding out that digital care works well and that they eventually adapt to it, even those physicians that are more sort of tech resistant, but it's the patients that are identifying the convenience. There's no place like home. The more we can do for them at home, the more effective we're going to be. And essentially what we see with these remote therapeutic monitoring codes is that CMS believes that this monitoring space is improving patient outcomes and lowering costs. I mean, that's my, I think, obvious takeaway here as they're expanding now the remote monitoring elements of care to other types of practitioners and other types of essential data. From a personal standpoint, why I got into this area of remote care and digital care is having grown up as an only child with two disabled parents, both of which were in wheelchairs. And I sort of, in the 90s, was remotely monitoring them before that was a real thing, because I would call them on a regular basis every day, multiple times a day. And in just speaking to them and asking them about symptoms, getting their, what we would call today, patient-reported outcomes, avoided numerous hospitalizations and other serious issues and emergencies. So early on, just in what I felt was helping my parents, I realized that if we can get to patients when they're ambulatory, outside of the office, and monitor them from home and see how they're doing, we can make a big difference, especially in a patient-centered style of program. And that's where HealthSnap came from. I mean, there's a lot of RPM companies out there, but we wanted to use technology and we wanted to combine it with the clinical data, the conventional care, by placing, at the time, students in doctors' offices and getting assessments on lifestyle and other elements of their care. And eventually we wanted to streamline the system by combining home devices and wearable technology as it grew, along with evidence-based strategies to help get more information, a more comprehensive picture of how patients were doing. So eventually, as the demand started to increase for remote healthcare technology to help patients during the pandemic, et cetera, we were serendipitously poised to be able to step up in that position. And we recognize that now patients are becoming more and more accustomed to the convenience of home-based care. And these RTM codes are just another step in that area, which again, is why I'm really excited about it. So instead of just talking about why I'm excited about it, let me get into it, because that's what we're here for. So, first, what I think is great about the RTM codes is the ability to value clinically other types of essential data. The example that I would give is from a scientific perspective is that if you're doing a 12-lead EKG on a patient who's in a stress test and you see what might be an ST segment depression, you immediately look up at the patient and you say, hey, how you doing? Because they might be ischemic based on what we're seeing on the EKG, of course, but we also want a more comprehensive piece of information. We want to get, from the patient directly, how are they doing? A heart failure patient let's say, is remote physiologically monitored for body weight and or blood pressure, right? And you see in a few days, this heart failure patient is gaining weight and their blood pressure is getting higher. And we're thinking that they're having worsening heart failure, or they're not taking their diuretic and their ACE inhibitor, or what, we're concerned about this patient. And then when you go to speak to the patient, you recognize that it was his birthday weekend and he gained a lot of weight from eating a lot of cake and stuff, and then he's hungover, and that's what's causing his blood pressure to go up. And the reality is, it's not the same as if you call him and you find out that he's suffering from leg fatigue and shortness of breath. So combining the remote physiological data with additional really valuable data, like patient-reported outcomes, really gives us a more comprehensive, a more clearer picture and understanding of how patients are doing. And that's why, from a scientific perspective, I was very excited to see that self-report data is going to come in. As I was working on my PhD, I was working in geriatrics and looking at ways to combat sarcopenia and preserve function in the elderly, and trying to use different tests to look at functional independence. And we figured out, what a really good test is? The short form 36, where you literally ask the patient, hey, how hard is life for you? How difficult are these activities of daily living? And that self-report data was really a great predictor of the patient's level of independence. And that's why patient-reported outcomes are so valuable. So CMS recognizes that the essential data does not necessarily have to be physiological, and some key ones here that they mention, of course, are pain levels. Pain levels critical. Like if you're seeing a patient's blood pressure go up, and then you find out that they, have bursitis or something, the pain could be describing the sympathetic response and the changes in blood pressure. And we don't want to just medicinally care for patients. We want to, from a lifestyle perspective, keep them not just alive, but keep them living well. And understanding a patient's pain, like in a cancer patient, for example, or a patient recovering from surgery. All these are just really important pieces of data that we want to measure outside of the office on a regular basis to help better care for our patients. Medication compliance is like a no-brainer, right? I mean, there was a review article that I read years ago, but it's always stuck with me, that they found that about 30% of medication prescriptions were never filled. And of those medication prescriptions that were filled, about half of them were not taken as prescribed or not taken consistently. And that was responsible for thousands, hundreds of thousands of deaths and hospitalizations, and cost the American healthcare system like $300 billion a year. And we know that keeping the patients aligned with that medication adherence is so critical. When we work with the remote patient monitoring, with the physiological data, we also are contacting the patients and discussing with them their medication compliance already, even before RTM codes came out, because we recognize it to be such an important element of the patient's care. So if we have the opportunity to work with them from an ambulatory perspective, medication adherence, using some type of software, whether it be patient reporting that they're taking their medication on a regular basis, or a device that actually measures the weight of a sample of medicine decreasing as they're taking their medicine regularly. And then, of course, therapy adherence. You talk to physical therapists, at least the physical therapists that I've spoken to, and one of the most frustrating elements of their job is that they know when patients go home, a lot of what they're working to improve will just revert back to where it was, or close to back to where it was, and then the patient will continue to be dysfunctional. So physical therapy gets at that root issue of whatever's causing the pain or lack of function, instead of just masking it. And therapy adherence, therefore, is really critical. And if there's software that can measure therapy adherence in OT or PT, in the world of OT or PT, it's obviously really important. An example that I often give is that knee pain, chronic knee pain, not like an acute knee injury like from an ACL or something, but like chronic knee pain, the knee is usually the victim, not the culprit. So usually it's like an ankle or a hip or a back issue causing the knee pain. And that's what's great about physical therapists, is that they're getting at that root cause. They're working on whatever the problem is. So like if someone has weak glutes and their hip is rotating improperly as they're walking, then that could be the cause of the knee pain. And then to get rid of the knee pain, certainly you could use NSAIDs and ice and rest and elevation to sort of get, lower the pain a little bit, but the root cause is the lack of strength in the gluteal muscles, or a lack of range of motion in hip flexors or something like that, which therefore is causing this knee pain and causing the patient to have a lower physical activity level. And with the pain and musculoskeletal issues and a lower physical activity level, we know from there we're going to see a whole myriad of cardiometabolic comorbidities start to creep in as well, because they're becoming less physically active. So pain levels, medication adherence, and therapy adherence using software is going to be a really, really big part of the RTM codes. And these are going to be medical codes. And so different types of practitioners outside of physicians and nurse practitioners can actually prescribe this. So I'll give you the specifics in a moment here. So as I said, RPM works really well when it's evidence-based and when it's patient-centered. I mean, that's what most of the data shows, that if it's patient-centered and the patient understands it's for them and for their benefit and it involves interactive communication with the patient, that's where we really see RPM do a phenomenal job. There's a January study that came out of the UK, published in the British Medical Journal, that found evaluation of blood pressure using digital interventions for patients with poorly controlled hypertension was really significantly better than conventional methods of treating hypertension, through just improvements in blood pressure to the effect of about 2 medications, like a 12-point reduction in systolic blood pressure, as well as improved medication compliance. They actually found that when you transfer the data that they found from the euro to the dollar, that for every millimeter of mercury decrease in blood pressure this RPM program provided, it saved roughly around $19 per millimeter of mercury of blood pressure reduction. So if you're talking about 1,000 patients, you're getting up to about $250,000 of savings for the healthcare system, which value-based care groups and payers should be really interested in, because it's showing the effectiveness of remote patient monitoring. And with our care navigators that we use that are doing the remote patient monitoring, yet like RTM, collecting patient-reported data, talking to the patients about their medication compliance and other areas, we're seeing that the patients almost across the board, nearly 100%, have improved self-efficacy, improved health literacy, and they're making some form, even if it's subtle, of lifestyle change to improve their physiological data. So because of this, RPM's working so well. Let's open it up now to RTM and expand this system in the future of healthcare, so that it's not just a wave of change, but we're really seeing what really amounts to a tsunami of change in the world of healthcare. So in a nutshell, the remote therapeutic monitoring, as I mentioned before, is going to expand these two things. We're going to expand greatly on the types of patient data that can be remotely monitored. I'll show you the codes in a moment and explain a little bit about those and how they sort of parallel in some ways the RPM codes. It's also going to greatly expand the type of practitioner who can prescribe the service. And unlike RPM, these are general medicine codes. RPM are evaluation and management codes. So the qualified healthcare providers like physical therapists, occupational therapists, registered dietitians, clinical psychologists, other types of practitioners can bill under the RTM code, but it doesn't allow for incident to billing of clinical staff. Therefore, it's the occupational therapist discussing the time spent, the 20 minutes of going over the data, the time spent educating the patient on how to use a certain device. All that is going to be conducted by a practitioner, not by clinical staff. But this is, super exciting that we get more types of data and a whole broadened level of types of practitioners who can prescribe these codes now. Taking advantage of technology and taking advantage of the convenience of home. And if you couple telehealth and telewellness and telemedicine with the ability to remotely monitor patients, we really see a new wave, tsunami wave of healthcare. So these are the codes that have been released in the updated CMS RTM code documentation. And there are some similarities to RPM, and what they believe is that people that have looked at this and the way it's been worded is that really the reimbursements will most likely be similar in parallel many ways as well, the RPM, because in the end, whether it's a physician prescribing RPM or whether it's a qualified healthcare provider prescribing RTM, in the end, you're going to see better patient outcomes and a reduced overall cost of care, which is what CMS aims to achieve. So the reimbursements will probably be similar to what we're seeing with RPM right now. So the initial setup, the 98975, is a lot like the 99453 RPM code, where here it's just getting the patient educated on how to use the device and setting it up. And there's a lot of time if it's, especially the Bluetooth devices, because then you're talking about an app, typically in an older type of patient, trying to figure out how to use the app and hook up their device. Even the word Bluetooth can throw them. They might think that suddenly you're talking about their dental care, or they're not that tech savvy, a lot of these patients. And this is a lot of time spent sometimes just setting up a patient with a medical device. Now, the two examples that CMS give right now for supplying the actual device would be the respiratory system device. So let's say it's a inhaler that can notify us when a patient has used it and feeds back, through cellular or some other mechanism to a patient portal, and we can see how often the patient is using the inhaler. And to supply that device, the 98976 code is available. And there's also, if you're supplying a device that can monitor the musculoskeletal system in some way or another, that's the 98977 code. And these more or less could sort of resemble the collection of data through the 99454 code that we see in RPM. Now, I'll talk about it in a moment, but with patient-reported outcomes, if it's using software as a medical device, where patient is just kind of reporting things that they're doing and how they're feeling, but they're not actual FDA-approved devices for respiratory monitoring or musculoskeletal monitoring, the reimbursements will be less because the 76 and the 77 code of RTM should not factor in to that model. But it's still, these are important things to obtain from patients. So when we look at the number 4 and number 5 here on the RTM, we know that the first 20 minutes spent by the practitioner, specifically by the practitioner, not clinical staff, going over the data and discussing with the patient using interactive communication, which is an important part of this. Interactive could be phone, could be video, would be the 98980 code, which if you look at RPM is similar to the 99454 code. And then every additional 20 minutes, again with interactive communication with the patient, performed by the actual practitioner, would be the CPT code 98981, which is like the 99458 RPM code. And again, likely to be reimbursed in a similar fashion to that. So RTM codes, as I mentioned, are classified in the CPT manual as medical or medicine codes. Clinical staff does not count towards those 20 minutes. So I know I mentioned that once already. I just want to really emphasize that. So they are available to the other types of qualified healthcare providers where practitioners are going to be the ones doing the time spent. There's not incident to billing. However, there is some language that might tend to suggest that if an MD or a nurse practitioner orders RTM, remote therapeutic monitoring, that in this particular case, it could be that clinical staff can actually contribute to the 20 minutes. But I think that seems to be rather ambiguous, and we're going to have to wait to see a little bit down the road what CMS comes out with there. So as I finish up here, I wanted to show you some examples of what just came to mind to me recently, just to discuss here today with you all. Chronic kidney disease is a perfect use case where we got physiological measures that are really important. And I think that payers and ACOs and other value-based care groups, they want to see like a really comprehensive picture of the patient. So combining RPM with RTM would make sense. So you got chronic kidney disease and you're measuring body weight or blood sugar. And in addition to that, you're asking the patient how their appetite is and if they're having muscle cramps and nausea, because all of this is important. It gets really at that comprehensive picture of the patient in a more detailed way. Cancer, another obvious one. Maybe you're looking during a chemotherapeutic intervention on a cancer patient, you're looking at for febrile neutropenia. So you're measuring body temperature and looking at neutropenia. Or maybe you're just looking at, with cancer cachexia, BMI and grip strength from a physiological perspective, but then On the RTM side, you're looking at things like energy and pain and nausea, or maybe grip strength is an FDA-approved device that can be used to measure musculoskeletal performance and maintenance of strength over time in these patients, trying to monitor for sarcopenia. We also see COPD. If you think about the Bode score and how it's so critical to looking at predicting mortality in these patients and function, there's physiology and RTM involved. So maybe looking at body weight for BMI and, of course, arterial oxygen saturation. Or on the RTM side, actually, it should be peak respiratory flow measures or FEV1. You're looking at these other measures with an approved medical device. And RTM, you're looking at how often they're using their inhaler, patient-reported outcomes like night coughing and wheezing and shortness of breath and that kind of thing. And appetite, of course, being very important. And when we look at that Bode score, BMI, which is a physiological variable, is really just one part of it. But things like physical activity and walking distance for exercise capacity, like the 6-minute walk, or shortness of breath and airway obstruction, which would fall under the RTM code. We can get a Bode score remotely on patients and really track and predict mortality from a complete remote perspective, which is a game changer for this really important and hard to manage chronic disease. Last one that's a little bit of an oddball here is atrial fibrillation, because atrial fibrillation, the blood pressure measurements from a remote physiological monitoring are a little tricky unless you're also using a device that is accurately predicting when the patient is in AFib. So maybe physiologically you're looking at blood pressure, but you're also looking at arterial oxygen saturation or heart variability. But what will be really important in these patients are the signs of AFib, like fatigue and palpitations and stuff. So, again, I think it's an exciting time if you believe in remote care, the way that I do. And I think a lot of you that if you're joining the webinar here, you probably feel similarly to me in that case. And I took a few questions here because of time. We have about 5 minutes. So I'll just go through some of the questions. And some of these questions came in early, so I'm going to try to see some that are not redundant for things that I mentioned. So one of the questions was just what kind of device can be used for RTM? And maybe I didn't mention it enough, but it is important that these devices, they give the example of the musculoskeletal and the respiratory devices, but they meet the FDA definition of being a medical device. So those are the types of devices, these FDA approved medical devices for respiratory and musculoskeletal assessment would reach those setup codes that exist in the RTM literature, 98976 and 98977. Now, what can also be used is software as a medical device. So this is where you get that patient-reported data, that self-reported data that is also really important. And the issue, of course, is that this isn't necessarily an FDA-approved process or device, so fitting into the musculoskeletal or respiratory realms. So there's less room for reimbursement, but again, it's going to focus on the patient and it's going to give more comprehensive care, better care. So, the goal, at HealthSnap, we keep that focus on what are we doing for the patient. We're not concerned about reimbursement. That's really, on the physicians. If they get reimbursed, that's great. But we really think that what we have is a really good program for the patients to remotely care for them. And I think that should always be the focus. Okay, the other question here. Okay, how many days of data must the device monitor? I don't think I mentioned that. And I just said it was similar to the RPM codes. So for the 98975, 98976 and 98977, the RTM device must monitor at least 16 days of data per every 30-day period, which again, very similar to the RPM. So that's for the 75, the 76, and the 77. All of that must be fit into a 30-day period and have at least 16 days of data within that 30-day period. So we're just trying to get the patients like every other day, at least, transmitting their data so we can get some really good ambulatory measures. Let's see, 2 more. Can you explain again how patient-reported data can be used in RTM? So what the CMS has stated at this point is that manually entered data, self-report data, can be part of the non-physiological assessment and data purposes of this RTM program. And you think, especially when you consider like clinical psychology, or you consider pain, for example, these things are, and even, did you take your medication today? Those types of things are self-entered patient data and does fall into the realm here. And this information can be digitally uploaded via a device, so it becomes software as a medical device. And but for the other devices, for the musculoskeletal and for respiratory, again, they have to be fitting into that FDA definition of a medical device. So we have the SAMD, we call it, software as a medical device, which it differs. It doesn't necessarily have to meet the FDA criteria as an actual medical device, but it's going to be software being used as a platform for that self-recorded and self-reported data manually entered into the device. Okay, and then I apologize if that was a little redundant. A lot of the questions came in probably as I was going through. So, okay, and the last one here, do I feel that RPM and RTM are going to last? And admitted, some bias here, because I believe wholeheartedly in this being an effective means of proactive patient care. But I think all signs are that, yeah, no question, because we're seeing an expansion. We're not seeing a regression on what we're doing in digital and remote care by adding the RTM codes, and we're seeing a renewal of the RPM. That it seems that this has been working well from CMS vantage point. And then another thing that I hear often is, our physicians, are they taken to digital care and telemedicine and remote monitoring? And although that's important, the reality is, I think we're going to get to a point where that's not going to matter so much, because, it matters clearly, but the reality is, as soon as patients realize the convenience of being able to get a lot of their healthcare done from home, it's really not going to be up to the clinicians as much, because the patient's going to be looking for it. I joke around with my stepdaughter is 20 years old, who has Publix, like literally, which is like a grocery store down here in Florida, like right across the street from her house. Honestly, it's probably 20 steps from her couch, basically. And she still orders her groceries online. And she's perfectly healthy and capable, So if you can imagine a 20-year-old healthy person that prefers to order their groceries than just take a few steps to go to the grocery store because of the inconvenience. Imagine being that heart failure patient that lives a long way from the hospital, and how arduous making that appointment is. And it's an all-day event, right? And if they can do this from home, you better believe they're going to keep wanting to do it from home. So this shift is going to be continuing to grow dramatically, in my opinion, over the next several years. And I just think that the pandemic obviously pressed the accelerator on this a bit, but this is going to be here to stay. So once they recognize it, it's going to be here to stay. It's also interesting, if you look at the data, patients and doing online ordering for the holidays, online shopping and things. To everyone's surprise, the baby boomers are actually leading that way. They are really, taking to remote shopping. So, the technology isn't getting in their way. They recognize the convenience, and it's just a shift that we're going to see. And that shift is going to become more and more available, more and more accessible every single year. The devices that we're using today are not going to be as good even as the devices that we use tomorrow for monitoring patients remotely, et cetera. So I think it's a great time for all of us that are in this field. And I went over a little bit by a minute, but I really appreciate you being here today. And I look forward to you hopefully joining us for some future webinars that we'd like to offer down the road. Thanks.